Welcome back to the deep dive. Today we're tackling a tiny organism with a huge impact, Helicobacter pylori, H. pylori.
That's right.
Think of this as your sort of focused strategy session for getting the essentials down, Pat. We've got the key info, and our mission today is really just to give you a clear, memorable handle on this bug.
Exactly. We'll cover everything needed for revision, from the definition right through to complications.
Yeah, we'll hit definition, etiology, risk factors, pathophysiology, differentials, epidemiology,
Clinical features, investigations, management.
prognosis, and complications. All the key bits. Let's jump in.
Let's do it. Consider this your guided tour through the really crucial stuff about H. pylori. We want it to stick.
Okay, so first things first. What exactly is H. pylori? The definition.
Well, fundamentally, it's a spiral-shaped bacterium, gram-negative, and it mainly lives in the stomach.
Spiral-shaped gram-negative stomach. Got it.
And what's really striking, I think, is just how common it is. It's actually the most common chronic bacterial infection globally.
Wow. How common are we talking?
Affects about half the world's population, roughly.
Half the world. That's huge.
It is. But you know, the interesting thing is, most people who have it, they don't have any symptoms, asymptomatic.
So they don't even know it's there.
Often, no. But it is a major player in some pretty significant conditions. Remember the acronym PUGA?
PUGA. Okay, what's that stand for?
P for peptic ulcers, U is implied with ulcers, G for chronic gastritis, A for gastric adenocarcinoma, that's stomach cancer.
Right.
And the second A, well, let's use M for malt lymphoma, so QGM if you like, or just remember malt lymphoma separately. Peptic ulcers, gastritis, adenocarcinoma, malt lymphoma.
TGAM. Peptic ulcers, gastritis, adenocarcinoma, malt lymphoma. Okay.
Yeah. And while we know it's linked, exactly how it triggers all these things, well, that's still being worked out in detail.
Okay. So if half the world has it, how does it actually spread? What's the etiology?
The thinking is it's mainly oral, so like saliva,
Okay.
and fecal-oral transmission, often linked to sanitation levels. And interestingly, infection often happens in childhood, probably because of closer contact. Maybe hygiene isn't as strict then.
Makes sense.
Yeah, and contaminated food or water can also play a role. So think close contact and potentially things you ingest.
Close contact, food, water. Simple enough. Now, are some people more likely to get it? What are the risk factors?
Yeah, definitely. There are factors that increase the risk.
Yeah.
You can use the acronym PCOD for this one.
TCLD.
P for poor sanitation, O for overcrowded living conditions, L for lower socioeconomic status.
Okay, PCOL.
And D, well, maybe D, for developing countries where these factors are more common, though lifestyle choices might play a bit of a role too, but it's less defined. So PCOD helps remember the main environmental links.
PCLD, poor sanitation, overcrowded, low socioeconomic status, developing world context. Got it.
Environments where hygiene is tricky and people live close together, basically.
All right. Now, we mentioned PTM, the conditions associated with H. pylori. Let's really nail down those associations.
Okay, this is really key for recall. The connections are strong. Peptic ulcer disease H. pylori is the big one here.
How big?
Responsible for about 95% of duodenal ulcers, think down in the duodenum.
95%.
Yeah. And about 75% of gastric ulcers, think grounded in the stomach itself.
Okay, 75% gastric. Still massive.
Definitely. Then there's gastric cancer. Having H. pylori significantly increases your risk.
Right.
And then malt lymphoma, that's B-cell lymphoma of mucosa-associated lymphoid tissue. This is where it gets fascinating.
Yeah.
If you eradicate the H. pylori infection, the lymphoma can actually regress, disappear, in about 80% of cases.
80%. Just by treating the infection.
In many early-stage cases, yes. It's quite remarkable. Treating the bug treats the cancer.
Oh, okay. What else?
It's also associated with atrophic gastritis, which is a thinning of the stomach lining.
Okay.
But here's where you need to be careful. Gastroesophageal reflux disease, or GERD.
Right. Heartburn and reflux.
Exactly. The link there isn't clear-cut. In fact, routine H. pylori testing or eradication isn't recommended for GORD treatment.
Oh, really?
Yeah, and some studies even suggest H. pylori might offer some protection against severe reflux esophagitis. It's still debated, but the key point is don't treat H. pylori just because someone has GORD.
Okay, so strong links with ulcers, cancer, atrophic gastritis. But GORD is different. maybe even protective.
Precisely. It's complex.
Okay, let's get into the nitty-gritty then. How does this spiral bug actually cause all this trouble? The pathophysiology.
Right. So it's got some pretty clever tricks. Remember, it's gram-negative, spiral-shaped. That shape helps it, corkscrew through the stomach mucus.
Spiral and slide, as you said before?
Sort of, yeah. Spiral and burrow, maybe.
Sure.
And it has flagella, little tails, to help it move to safer spots.
Safer spots in the stomach.
Yeah, areas near the stomach lining where the acid isn't quite as harsh.
Yeah.
But its main survival trick is an enzyme called urease.
Urease.
It secretes urease, which breaks down urea naturally present in the stomach into ammonia. Ammonia is alkaline.
Ah, so it neutralizes the acid.
Exactly. It creates its own little less acidic microenvironment, like an acid shield.
Clever bug.
Very. And it's genetically diverse. Certain strains, particularly those positive for genes called VAC-A and CAG-A, seem to be more strongly linked to ulcers and cancer.
VAC-A, KA positive strains are worse.
Generally associated with more severe outcomes, yes. And in terms of damage, it releases toxins like PAG-A itself, which get injected into stomach cells and disrupt them, causing inflammation and damage to the mucosa.
Okay, so it burrows in, shields itself, and then releases toxins.
That's a good summary. And remember that huge prevalence, over 50% globally, it's a major driver of ulcers, significant gastric cancer risk increase, especially if you also have that atrophic gastritis.
Right.
And again, that MULT lymphoma point eradication leads to regression in 75–80% of cases. And the GARD relationship remains, well, controversial.
Okay, understood. So if someone comes in with stomach pain, bloating, that kind of thing, what else could it be? The differentials?
Yeah, you always need to think about other common causes. Top of the list would be gastroesophageal reflux disease, GERD, or GORD. Very common cause of similar symptoms.
Right, GORD.
What else? Non-steroidal anti-inflammatory drugs.
Yeah.
NSAIDs. Things like ibuprofen, naproxen.
Yes.
They're notorious for causing stomach upset, gastritis, and even ulcers directly. So you always have to ask about NSAID use.
So Gordachard and NSAIDs are the big mimics to rule out.
Definitely the key ones, yes.
Okay, let's zoom out again. Epidemiology. How common is it in different places? You said 50% globally.
Yes, but there's variation. In the UK, for example, prevalence has actually been going down quite a bit.
Oh, good news.
Yeah, it's often below 15% in many areas now and still declining, likely due to better sanitation, smaller families, maybe less antibiotic use, historically allowing resistance now. It's multifactorial.
Interesting. But globally?
Globally, it's still much higher in many regions, particularly developing countries, strongly linked to those PCOD factors. Lower socioeconomic status, sanitation issues, overcrowding.
Right.
And there's also a general trend for prevalence to increase with age. Probably just reflects more chances for exposure over a lifetime.
So lower in developed nations like the UK, higher in developing, and generally increases with age. But overall, still over half the world.
That's the picture, yes. A huge burden.
Okay. So what might someone actually experience if they do have a symptomatic H. pylori infection? Clinical presentation.
Well, the common symptoms are things like abdominal pain, usually upper abdomen.
Like dyspepsia?
Exactly, dyspepsia. Also bloating, maybe some belching, nausea, sometimes heartburn, although we know the Gurodilling is tricky.
Okay, the usual suspects for stomach trouble.
Pretty much. But then there are more serious signs, potential red flags.
The red flags. What should we look out for?
Things like pain in the epigastrium, especially if it's related to eating meals, feeling full really quickly, like after only a few bites, that's early satiety.
Right.
Lack of appetite. Fatigue could be a sign of anemia from slow bleeding. And obviously, dark tarry stools melena indicating significant bleeding.
Melena, definitely a red flag.
Absolutely. And then there are the really worrying ones, often summarized by the acronym LON.
LON, okay.
L for loss of weight, unexplained. A for anorexia, loss of appetite. W for worsening, persistent, or new-onset dyspepsia, especially over 55. N, maybe N for nocturnal pain or symptoms that wake you up. Or think bleeding signs like anemia or melanina. Vomiting, persistent vomiting is a concern.
LON.
Yeah.
Weight loss, anorexia, worsening new dyspepsia, 55. Nocturnal symptoms, nausea, vomiting, bleeding signs. Got it.
Yeah, those need attention. Also check for lymph nodes, especially left supraclavicular around the umbilicus or left armpit.
Okay. And how do we approach assessment?
Well, NICE guidelines in the UK are pretty clear. If someone's 55 or older with new dyspepsia and weight loss, that's an urgent 2-week weight referral for endoscopy.
Urgent referral.
Right. If they're over 55 with treatment-resistant dyspepsia or dyspepsia plus other concerning features from LON, consider a non-urgent referral. Always check their medications. Could drugs be causing it?
Good point.
Then you might consider empirical treatment with a PPI, or you might go for H. pylori testing first, the test and treat strategy.
Test and treat. Okay.
A really crucial point, though. If you're going to test for H. pylori, the patient needs to be off PPIs for at least 2 weeks beforehand.
Why is that?
Because PPIs suppress the bacteria, they don't kill it, but they reduce its activity enough to potentially cause a false negative test result. Same goes for antibiotics. Need a 4-week washout.
Okay, 2-week PPI washout, 4-week antibiotic washout before testing. Vital.
Very important. And one other thing, if someone needs to start long-term NSAIDs, it's generally recommended to test for and eradicate H. pylori first, if present, to reduce their risk of getting an NSAID-induced ulcer.
Prophylactic eradication before NSAIDs. Makes sense. Right, so testing, how do we actually do it? What are the investigations?
Okay, the main non-invasive tests, the ones usually done first in primary care, are the 13C urea breath test or a stool antigen test.
Breath test or stool test? Which is better?
The breath test is often preferred if available. It's very accurate. Both are good, though. These tests are mainly for people with symptoms, especially active or past ulcers, or those in high-risk groups for stomach cancer. We don't routinely screen everyone.
Okay. How does the breath test work again?
You drink a liquid containing urea that's labeled with a safe isotope, carbon-13. If H. pylori is there, its urease enzyme breaks down the urea,
Releasing the carbon-13.
exactly, as carbon dioxide, which you breathe out, and the machine detects the labeled CO2. Simple concept, very effective. Sensitivity and specificity are excellent, like 95–98%.
Breath and breakdown. Got it. And the stool test.
That one detects H. pylori proteins, antigens, directly in a stool sample. So, stool for the bug. Also pretty accurate. Sensitivity around 90%, specificity 95%.
Okay. What about blood tests?
Blood tests detect antibodies to H. pylori. The problem is they're less accurate. Sensitivity maybe 85%, specificity 80%, and crucially, antibodies can hang around for months, even years after the infection is gone.
So not good for confirming eradication?
No, definitely not. They mainly show past exposure, not necessarily active infection, so generally less useful now we have breath and stool tests.
Right. So breath or stool for non-invasive. What if someone's having an endoscopy anyway?
Then you can do tests on biopsy samples taken during the scope. There's the rapid urease test, often called the CLO test.
CLO test?
Yeah, you pop a biopsy into a gel containing urea and a pH indicator. If urease is present, it produces ammonia, changes the pH, and the gel changes color. It's quick, done right there. Think biopsy for quick urease. Very accurate, too, similar to breath tests.
Quick color change.
Right.
Okay.
You can also send a biopsy for culture, trying to grow the bacteria in the lab.
Why do that?
The main advantage is you can test which antibiotics the specific strain is sensitive or resistant to. Useful if treatment fails, but it's less sensitive initially, maybe 70%, and takes longer.
Right, for antibiotic sensitivity.
And finally, histology. A pathologist looks at the biopsy under a microscope. Scope and see. Highly accurate, 95–99% sensitivity and specificity. Can also assess for gastritis, atrophy, metaplasia, etc.
Okay, lots of options, especially with endoscopy. But breath or stool are the usual first steps.
Generally, yes. And remember, whichever test you use initially, after treatment, you need to retest to confirm eradication, usually with breath or stool tests, respecting those washout periods.
Confirm eradication. Key point.
Yeah.
So we found it, we need to treat it. How? Management.
Right. Treatment is usually combination therapy, antibiotics to kill the bug, plus an acid suppressor, usually a proton pump inhibitor, PPI, like omeprazole, lansoprazole.
Why the PPI?
2 reasons. It helps the stomach lining heal from any damage, like ulcers, and by reducing acid, it actually makes the stomach environment less hostile for the antibiotics, helping them work better.
Okay, antibiotics plus PPI. What's the standard combo?
The standard first line is usually triple therapy. That's a PPI plus 2 antibiotics, typically clarithromycin, and then either amoxicillin or metronidazole.
PPI, clarithromycin, amoxicillin, or metronidazole.
Yes. The course length is usually 7 days now in the UK, and optimized duration used to be longer sometimes.
7 days. Okay. Is there anything else?
Well, in some situations, maybe high clarithromycin resistance areas, or sometimes a second-line quadruple therapy might be used. That often involves a PPI, bismuth, which has antibacterial effects, and 2 other antibiotics, typically metronidazole and tetracycline.
PPI, bismuth, metronidazole, tetracycline, quad therapy.
Yeah. Whichever regimen, it's really vital the patient completes the full course, even if they start feeling better.
Compliance is key.
Absolutely. Side effects are usually mild, but stopping early risks treatment failure and promotes resistance.
Right. Any other advice?
For patients who also have ulcers, definitely advise smoking cessation and reducing alcohol intake as those hinder healing. And generally, we offer eradication therapy to anyone who tests positive because of those long-term risks, like cancer.
Offered to all positives. Good. Does it matter which PPI?
Not really. At equivalent doses, they're generally considered similar in effectiveness for this purpose.
Okay. What if the first treatment doesn't work?
Then you move to second-line therapy. That often involves using different antibiotics, maybe the quadruple therapy if triple was used first, or adjusting based on known resistance patterns or ideally culture results if available.
Resistance is a growing issue, isn't it?
It is, unfortunately, especially to clarithromycin and metronidazole. That's why using combination therapy is so important and why specialist advice might be needed if treatments fail. Culture-based therapy is the ideal then.
Makes sense. So what are the main benefits of actually getting rid of H. pylori?
The benefits are really significant. You can remember RUPRE. R for reduced ulcer recurrence. If you have an H. pylori ulcer and eradicate the bug, the chance of it coming back drops dramatically.
Okay, R for reduced recurrence.
U for preventing ulcer bleeding, specifically recurrent gastro-duodenal bleeding. Very important.
U for ulcer bleeding prevention.
P for proposed first-line treatment for early-stage, low-grade gastric malt lymphoma. We mentioned that remarkable regression.
P for proposed MALT treatment.
And RE for recommended eradication before precancerous lesions, like severe atrophy or intestinal metaplasia, develop, trying to prevent progression to cancer.
RE for recommended early before precancer. RUPRE. Got it.
Yeah. Reinfection after successful treatment can happen, but rates vary depending on the region and exposure risks.
Okay. What about follow-up after treatment?
As we said, confirming eradication is key, especially if symptoms recur, or definitely in anyone who had a peptic ulcer.
When do you retest?
For ulcer patients, usually retest 6 to 8 weeks after finishing treatment. Use a breath or stool test.
6 to 8 weeks post-treatment.
And remember, don't use serology, the blood test, to check for eradication, because those antibodies can stay positive for ages, maybe up to a year or even longer.
Right. No blood tests for follow-up. Okay. Can we prevent getting it in the first place?
Prevention is tricky because transmission isn't fully understood. Good general hygiene, safe water, safe food prep, the basics help.
Makes sense. Anything else?
There's some research looking at probiotics, like certain lactobacilli strains, potentially reducing H. pylori activity, but it's not definitive prevention or treatment yet.
Probiotics maybe, but needs more research.
Yeah, and the idea of eradicating it in everyone, even asymptomatic people, is debated. The risks versus benefits need more evaluation on a population level. There are also tentative links being researched with things like heart disease and fatty liver disease, but again, more work needed.
So still lots we're learning. What about a vaccine?
Vaccine development has been slow, there have been challenges, and maybe other priorities have overtaken it somewhat. It's complex.
Okay. And always the disclaimer to consult a professional for actual treatment advice.
Absolutely essential. This is for revision, not self-treatment.
Right. So overall, what's the prognosis if someone gets treated?
Generally, it's very good. With the right treatment, cure rates are high, ulcers heal well, favorable outlook.
Good to know. And finally, if it's not treated, what are the potential complications?
It comes back to PGM, really. The main complications are the conditions it causes. Peptic ulcers, which themselves can lead to bleeding or perforation.
Serious stuff.
Yeah. And then the increased risk of gastric cancer and multiple lymphoma developing over time.
So PGAM, again, peptic ulcers, gastric cancer, multiple lymphoma, the risks of not treating.
Exactly. Those are the big ones to remember.
Okay, well, that brings us pretty much to the end of our H. pylori deep dive. We've gone from definition, how it spreads, risks, how it works, what else it could be, how common it is, symptoms, testing, treatment, outlook, and finally complications. Hopefully a solid overview for revision.
Yeah, hopefully that covered the key high-yield points clearly. It's such an important organism to understand, given its prevalence and impact.
Absolutely. And for more revision resources, check out pastthemsra.com and also freemsra.com for loads more helpful content. Thanks for joining us.
Thank you.
You know, considering H. pylori affects half the world, yet is often silent. It really makes you wonder, doesn't it? What are the bigger public health questions around widespread screening or even prevention strategies? Something to think about.
Definitely food for thought. Until next time.